patient. And then you could always confer with the patient. Whatever plan you are putting down, you have to confer with the patient. That means you have to use the patient preference, the diet history, the 24-hour record that you have taken, the usual intakes, the food records that you are doing, that you assess or you collected when you were doing the nutrition assessment. That is the same thing that you have to use so that it will not be so different. Like you involve the patient in the planning that you are um, doing, or even the caregivers of the patient. You establish the goals and expected outcome. Establish why we are doing this and what is expected at the end of the day. Are you expecting a specific weight reduction at the end of the day? Are you expecting the labs to be in a particular way at the end of the day? You have to be able to establish it and communicate with the client or the patient. And then you create a schedule of care. Always create a schedule of care. Let the patient know that this nutrition problem you are managing, I need to see you every month. I need to see you twice in a month. I need to see you in the next 2 weeks. It has to be established. You have to talk about it so that the patient knows that I am supposed to come back for the review. Okay? It's easier that way. So then when you are setting the objectives, always remember that your objectives for the client or patient should be the client centered or patient centered. You cannot do one meal plan fit all kind of intervention. Whatever you are giving the person should be achievable for the person. Is it something that can be achievable? What you are saying, is it quantifiable for the person? The meal plan that you have done. Let's say the person needs 1,800 calorie a day with maybe 60 grams of protein. How can you quantify it for the patient to understand it? Because the patient don't know what 1,800 calorie is. So your ability to change the 1,800 calorie into simple handy measures, simple household measures that the patient can be comfortable with and can do it well is very important. If it's a behavioral change, how are you going to put that behavioral change in a very simple form for the patient to understand? And then as we said, you must establish the goals and involve other members of the healthcare team. The patient has to know that your doctor will know, like he's part of the healthcare team. So then in case he's asking you, you can share what you have done. You can even talk to the doctor. If there's a need for referral, you have to talk to the patient about it before you even talk to the referring healthcare personnel you want to refer the patient to. Very important. And you do all that under the intervention objectives and then goals. And what will the patient do or achieve if the objective is met? You have to give the patient some expectation that if you are able to achieve this, this is what is going to happen. If you are able to achieve this loss of weight in 6 months time, we are hoping and we believe that if you are consistent and principled, we'll be able to lose 6 kg, which puts you in this BMI. That is a healthier one. All that has to be established with the patient during the intervention planning. Okay. And I decided to show this slide to show how some of the foods can be put in measurable and familiar measures. Okay, measurable and familiar measures. Like if you are teaching how protein quantity, how much a serving of protein looks like, how much of a serving of vegetables looks like, how much a serving of fruits and even starchy foods looks like. You can use some of these simple handy measures to be able to make it very relatable for the patient. All right, so we are saying that our goal of interventions should be stated immeasurable outcomes, as I said. So then the goal you are communicating to the client or patient should should be measurable. You should explain why you giving that consistent carbohydrate can reduce the sugars by maybe 10% at the end of 2 months or at the end of a month. You should be able to do that for the patient to really understand. And most of the time, it is more realistic when you do it with the lab test or the anthropometric measurement that you took. Okay, so you set targets. You set targets for the client or the patient. And then for the positive changes in dietary behaviors and lifestyle, it is also important that you talk about it and you set the goals using those one, the meal plan I'm giving you. We want a lifestyle change. It is gradual. This is how I want you to go about it. And this is the outcome that we are expecting out of it. It is always the best when the patient understands the intervention, when the patient is part, especially if the patient has a caregiver, if the patient is married. If the patient will allow for the partner to sit in, it has shown to have a better effect than dealing with the individual person. And then whilst we were talking about the planning domain, I said prescription, nutritional prescription. Nutritional prescription is the information in a summary, your intervention in a summary, the intervention that you are doing in a summary form. How is it so that when your colleagues come or when other healthcare teams sees it in your notes, it is easier for them to know a summary of all that you want to do for your patients. Okay, and usually it is determined using the assessment data, the PS statements, or the current evidence and policies and procedures, and then the patient preferences. All of them can be used to write the prescription in a very simple and straightforward manner, because the when you are documenting actual intervention, it's a little bit lengthy, but at least the prescription gives a very summarized part. And in other places where they have dietetic technicians who are helping the clinical nutritionist or dietitian, the prescription is the best way for the technician to actually know what to do for what instructions you have left to be done for the patient. Okay. And then when it comes to the implementing domain, we are just documenting. You document the care plan, the nutrition care plan in your notes, okay? And then you discuss the care plan with the patient or caregiver or with both of them, depending on who the patient is, whether the patient is conscious or not. You have to discuss it. If the patient is not conscious, you have to discuss it with a family member. If the patient is conscious and the patient is comfortable with the caregiver being part of the whole consultation, you discuss with them. Then individualizing treatment, that means you are putting down everything that's singly you are doing for that client or patient. If there's a need for the patient to take glucose data for you while the patient is in the house, or there's a food record you want the patient to take for you, you also document that. You document that so that the next time the patient comes, you'll be able to follow up. Okay. And then there are some things that you use for the intervention to really work. And most of the time, treatment can be improved by utilizing dietary modifications. That is when we do the diet plans or the menu plans for the patient. There's always a difference between a menu plan and a diet plan. A menu plan is a very elaborate way which have the days of the week and individual foods the person will take and the quantity. When you are doing a meal plan, you don't specifically put the dates. You just put the times the person is supposed to eat, the kind of foods the person can choose when the person is eating at that particular point in time. And always try and use evidence-based scientific rationales, evidence that are supported by high quality research when you are doing some of these modifications. It's also good to have educational materials available in your clinic where you will give it to people, so that it's not everything that you can say in the moment you are doing assessment and then diagnosing and even putting in some intervention. So if you have educational materials, it helps the patient to learn more about the condition later when they get to the house and remind themselves. Sometimes too, it has been shown that if there are some things you can change, because there are some medications that are being used that have seen to cause maybe weight gain, that have seen to increase the risk of anemia in clients or patients. It is always good to talk about it with the referring physician if it's possible to have a change of medication. If it's possible, they can change it. If it's not possible, then we work around it. It has always shown to have a very positive effect. So this one, I wanted to bring an example of a diagnosis, and then how the prescription is supposed to be written and how the intervention is supposed to be written. So if you look at the top here, the nutrition diagnosis was involuntary weight loss related to missing meals, as evidenced by loss of 7.5 kg over 3 months. So then our root cause is the missing of the meal. So then every intervention is going to relate to how the person is moving forward, will not miss meals like that. So we have taken our history and everything. But in summary, you see that prescription here, it is showing how much calories the person is supposed to eat in a day, and the fact that looking at the person, how the person is missing meals, we want the person to include one oral nutrition supplement. It can be Ensure, it can be any of the other ones. I think B. Brown has oral nutrition supplements. I think there's another one. I'm not so sure. And then the amount of protein the person is supposed to eat in a day, and then the fact that the patient was cancelled, because it's a behavioral change we want. We cancel the patient on a good eating pattern. So you see, it's a summary of what our intervention is. But when you look at the actual intervention that is recorded in the person's folder, we are saying that the patient should take 3 main meals, 4 to 5 hours interval. So it means that every 4 to 5 hours, the person is supposed to eat a main meal with 2 snacks in between the main meals and 1 best time snack. So it means that the oral supplement can replace any of the snacks in between. And it is written that a meal plan has been given. And then patient cancelled on healthy weight gain, emphasizing on good eating patterns and food modification techniques to make eating easier and pleasant. All right. And the patient, we want to pick data. So the patient has been given a food record to complete a 3-day food record, so that when the patient come for review, we will check for the adequacy of it. We are going to coordinate the care with the nursing staff that is working with the patient, the referring physician, and the patient's daughter, because apparently the patient came with a relative and it was the daughter who is supposed to care for that patient. So that daughter was part of the intervention discussion and everything. So that's why we are saying we are coordinating. And then we made them realize that we have to see them in a month's time. Okay, we have to see them. So we talk about it whilst we are planning and implementing the intervention. So in a nutshell, this is how an example of how an intervention can be written, and the prescription, which is the summary of what we want to do as an intervention. And the last step what your monitoring and evaluation goals are. And most of the time, your monitoring and evaluation is actually will measure the evidence or the signs and symptoms that were in your diagnosis. Okay, so you have to write so that when up, we will know what actually you want us to monitor and evaluate. What actually you don't do the monitoring or you don't document monitoring and evaluation when they come for the review. Whatever you want us to, or you want your colleagues or yourself to monitor and evaluate, should be in your notes. Should be in your notes. After the patients have left, you can continue writing up what is expected after discussing it with the patient, that these are the goals, these are the outcomes that we are expecting. You have to document it so that when the person come for review, that is when you are going to measure the outcome you have now and the goals that were set. Okay, so you compare them. If it was anthropometric measurement, you compare what was done and it is now. Okay, so then the main purpose of this step 4 is to see whether there is a progress, okay, with the identified nutrition problem, whether the signs and symptoms. That's why the last time when we were doing the PS statement, I said that your signs and symptoms should be measurable. Because if it's not measurable, then when the person returns, it is difficult for you to actually evaluate to know whether there has been any change. So you always have to remember that your evidence or your signs and symptoms of your PS statement should be measurable. So then you are asking yourself whether the person has improved or not. If the person have improved, you encourage the person. You echo what you said. You re-emphasize some of the things you said. If the person have a multiple comorbidity kind of thing, then you try and tackle the others, because the last time we said that try and have one problem at a time. So if the person is doing well, if the person is improving, then you can have another diagnosis that you are looking out for. Or if the person do not improve, when you evaluated the goals that were set and now what you are seeing, then you can redesign, reassess your patient and then put in motivation techniques or additional patient education that can help the person. Okay, and this slide, I just wanted to show the relationship that is between the actual PES statement and then the other things the care process. Okay, so we are saying that your nutrition assessment is actually feeding into your diagnosis. The assessment you are doing is the grounds on which you are going to find a nutrition problem to be able to diagnose. Okay, and then when you have written your nutritional problem, which is the first label of the nutrition diagnosis, the etiology or the root cause, that is the one that you are going to plan the intervention for. That is the one you want to have solutions for. So always remember that you are planning intervention to suit the etiology. And then the signs and symptoms are the one that you are going to monitor and evaluate. So your signs and symptoms should be something that is measurable, something that you can compare the initial assessment one to what came or the outcome that was it. Okay, so in a nutshell, that is the nutrition care process and the various steps that we go through in terms of the assessment through to diagnosis, through to the intervention, and then the monitoring and evaluation and how all of them coordinate with each other. So then our other objective was to know how to incorporate the nutritional care process into our hospital information systems, or how to use it in our care, because I don't think it's everybody or it's all of us that have the hospital information system. So whether you have it or not, you can still incorporate. But most of the time, if it's in the hospital information system, it really helps. It makes it easier and faster. Okay, it makes it easier and faster. And when we are using in the hospital information system, we use the ADIME concept. The ADIME concept, that means assessment, diagnosis, intervention, monitoring, and evaluation. We use those concepts, and evidence have shown that that format really delivers quality nutritional care. It helps you. It is quicker. It helps you to improve your input of your assessment and other things that you are inputting. So mainly what you do is that you should have the sessions in your system, the nutritional assessment session, and then the domains under the nutritional assessment. You have to bring all of them. You can either make it a space or you can make it a drop down. So if it comes to food and nutrition related, you have a section for that, and then you can type in, or it's a drop in that you can click. And then when it comes to the anthropometric assessment, you can put in and even configure it to calculate for you the BMI and other measurements that you take. It makes it more easier. The nutrition focused physical findings, there can be all nutrition focused physical findings. So the one that you see, you click. It makes it very easy and very fast. And then you have the clinical history space and all that. Whether there is medication history, family history, there can be a drop down with all that. So you just drop it and click yes or no if the person have whatever you want. And then you have a section for the nutrition diagnosis. Now, because the electronic nutrition care process technology is there, some companies can even buy or subscribe and actually put it in the system for you. So you don't need now to be going to search. You just, if it's intake problem, you just go to intake, and then it gives you every intake problem. You just click on it. It goes to the etiology. It goes to the signs and symptoms. You just click on it and find the one you want, and the machine puts it together for you. So you make it very, very easy if you have it in the hospital information system. And then when it comes to your nutrition intervention, you also have the domains, and then the terms that comes with it are there, and then you just fill in. Because the nutrition intervention mostly is personalized. You just fill in what you have or what the intervention that has been agreed upon with the patient and caregiver, or if it's in terms of enteral or parenteral nutrition, what in the intervention you have put together, you can put it there. You put your monitoring and evaluation, the outcomes that is being expected, you put it there. So it is very easy when you are not there, somebody going back into the notes and knowing how the patient was, what was seen, the diagnosis, the intervention. And then if I'm coming to see the patient, I know the outcomes you are saying that I should monitor and evaluate, and it becomes very, very simple. So then that is the end of our lecture. I want us to do a case study, but before then, if there's any question, you can ask, and then we will do one case study to see how best we can put together PES statements and put together a nutrition intervention. So then if there's any questions so far, you can ask, please.
Thank you, Harriet, for a good presentation. So before we go to a case study, anyone with a question? Yeah, Joseph.
Good evening. Thank you so much, Harriet, for your presentation and all the the nutritionists are available for this particular training. So I want to ask a question. You little bit tackled that, but I want to ask a question regarding the patient-centered care. So when when we are doing nutrition intervention, so what's the benefit on both sides for the clinician and also for the patient in terms of good outcome of the patient's problem? So because I have been seeing that most of in our clinics, most of the healthcare providers, they impose instead of listening to our clients and what they can do. So I want you to maybe to clarify on this, and also we can see we can weigh the benefits and for the patient-centered care, particularly in the nutrition side. Thank you.
All right, thank you, Joseph. So then now, nutrition care process is really patient-centered care. So whilst I was talking about intervention, you realize I keep on mentioning that you involve the patient, because patient preferences, it is very important to use patient preferences when you are putting down or you are planning an intervention. For example, if in the patient's 24-hour dietary record that you pick, the patient has said, I eat matoke, I eat sweet potato, and I eat Irish potato. So whatever intervention that you are going to do, it is very important that you use those food in a healthy way. The patient is at the center of care, and we are all trying to help the patient with what the patient knows how best to do. That is why I said it is not good, or it is not very scientific for you to have one cut fit all meal plans for every patient that comes. No, it should be an individualized meal plan, because the person who likes matoke, another person will like plantain, which is two different things. So if you are forcing me to eat matoke and I can't eat matoke, at the end of the day, I'm not going to do any of your intervention, and it will not work. If I don't have the economic status to buy what you want me to buy, especially let's say you have a diabetic, you have heard of quinoa. Quinoa is good, high in fiber, helps with controlling of sugars, and then you ask me to eat quinoa. What is quinoa? I've not even seen it before. I don't know how it tastes. I cannot eat it. So then that's why we are saying that you use the patient's preferences. Very important. You involve the patient in the planning of an intervention, and then even the outcomes. You realize that even when we're talking about the outcomes, what do we want to see when you come back? We are saying that talk to the patient about it. We want to see a decrease in weight. That is why we are doing this. That is why I'm giving you this target. Okay, let's work with this target. That is why I'm coordinating the care with your referring physician, and then your caregiver, and then everybody that surrounds your care. It means that the patient is the most important part of care. It is not the healthcare team, and what will benefit the patient is what we are doing in terms of the knowledge of the patient, the economic status of the patient, the community the patient is coming from. So it is very, very important for us to understand how patient-centered care works and how to actually implement it. Otherwise, we will have patients who will come over and over again, and they are even tired of us because whatever we are saying, it is not so achievable for that patient. I hope I've answered the question for you.
Thank you, Harriet. I think Joseph has been answered. So we don't impose to the patient. We just discuss, we advise, and we help the patient to understand and make a decision by him or herself. Any other questions? Sorry?
Rwanda Nutrition Society has raised their hand.
Okay. RINS, you can ask your question.
Yes, it's Adrian.
Yes, Adrian, you can
Yes.
ask your question.
Thank you for this time. Thank you for Harriet for the presentation. I want to ask, it's like two questions. The first one, all of us in Africa, specifically in Rwanda, we face the challenge of calculating the nutrition value of our available food, mostly available in the community. And I would ask to Harriet to tell us how can we face this challenge of calculating nutrition value. I know it will be like an advice. What can you advise us to just estimate the nutrition value of our food available in Rwanda? The second one was just a clarification to know, or you have mentioned that when you are monitoring your nutrition care plan, you just needed to record the food record of 3 days. So I wanted to know why 3 days, not 5 days, or the whole period between the first consultation and the next one. Why those 3 days? Thank you.
Okay. All right. Thank you. So then the first question, how to calculate. So yes, I understand that it's difficult because now Rwanda do not have a food composition table for the foods that are in Rwanda, but I think there's a Tanzanian food composition table that you can use, and there are very simplified ways of turning calories into food itself. Maybe we will talk about it in our next training, can be in that, how to turn calories into foods by using serving sizes. That one is more easier and realistic when you are doing it in clinic, because if you are going to use the Tanzania food composition table, it makes it very tedious. So then there are other ways by using serving sizes. Already there are some foods that have been measured. We can even measure it from the Tanzania food composition table. A group of us can sit down and then actually group the foods and come out with the serving sizes that are common in our region. Most countries, that's what they do. A group sits down, come out with the standards, how many servings of carbohydrates, how many grams of carbohydrates is in 1 serving of rice, and we use the Tanzania food composition. It is okay to use that one because you have common foods, so Rwanda gets its own. It is okay to use that, but then we have to really sit down and come out with the actual serving sizes, and then we can help everybody in the society, and then we can learn how to use the serving sizes too. It makes it very easy to do it in clinic. It is quicker to do that in clinic too. So for the first question, that's how I will answer it. It doesn't have a straightforward answer before we get to actually having something to practice with. And in a very easy way, we have to sit down. Maybe the Nutrition Society will sit down, a group of people. We come up using the Tanzania food composition to give the different serving sizes and the carbohydrates that are in it, and then the serving sizes of protein and all that. So then it's always, it's like a chart, so that it is easy to refer. The more you use it, the more you get conversant with it, so that you can say that 1 serving of rice is half cup of rice. So if I want to give 4 servings of rice, it's easy. I just give 2 cups, you see. So then using the serving size method is more easier than using the full composition method. But if we want to do that, we have to sit down and work and put it into the groups, and then we may have a training session to help people know how to use the serving sizes to do that. And concerning the question in the example, it was an example I was given. You can ask for a 30-day food record. You can ask for a 3-day food record or a 4-day food record, depending on what you want to know. Because the person was missing meals. The food record is to help you know why the person was missing the meals. And then when you have put the intervention in it, will the person miss the meals again? So then, depending on what you want, the one I wrote was just an example that I wanted to give. So it can be a 30-day food record to just see the number of times the patient or the client was missing meals, the reason why he was missing meals, so that when the person come back for review, it will be an avenue to re-counsel or educate on some aspects of the intervention that you gave. Okay, thank you.
Okay, thank you so much. I'm answered, but I can also suggest that we will have the training of 7 sizes, and I hope you will be present to train us about that.
It will be a pleasure.
Okay, thank you.
Okay, thank you, Harriet, and thank you for the people who asked the questions. But these people, Adrian and Joseph, are the ones that asked even in the last training. What about others? Are you guys here, or you're just showing us that you are online but you're not following?
We are following.
Any other person? So, is everything understandable? You don't have any questions, so we can proceed with the case study?
Esther, I think we can proceed, but I also have some question which is for the audience. Maybe I will ask it for after the case study. We can proceed, and I will.
Okay.
Yes, can continue.
Okay, so let's continue, Harriet.
Okay, so then we have this case study that we go through together, so that we'll see if we all identify the various stages, okay? And it has been put in a way that can be put in ADIME form in your hospital information system. It's easier, it has been put in that way. So this is a patient who has been newly diagnosed with celiac disease, all right? Celiac disease. So then, first of all, food and nutrition related history, she said that we use a 3-day food record or 24-hour record to find out what she's eating, because we know that celiac disease is when somebody has an autoimmune disease and they are allergic to the protein gluten in foods. Okay, so we want to pick a diet history, know what the person is eating. Then the knowledge, belief, because it's a newly diagnosed person, we want to ask about the knowledge about gluten and gluten-free foods, and the belief system the person have, the attitude towards food. We ask those questions relating to eating behaviors, like how many times do you eat, are there snacks, the times that you eat, and all that. Okay, and then we continue with the food and nutrition related history, including clinical history, that's the overall lifestyle, the activity level of the person, any family history or social history, because most of the time people with celiac disease, because it's an autoimmune disease, you find out that they have other family members who are also having some form of autoimmune disease, or even having type 1 diabetes, because some of them are predisposed to that. It informs you to make your implementation or the intervention better. Okay, any history of dieting or elimination diets, because most times somebody will come, they don't really know what is happening, but they have eliminated foods by themselves because of how it made them feel when they were eating it. Okay, so then you take a history on that, whether they are supplementations or medications, you can take some history with that. All right. And then the food access and ability to purchase gluten-free foods. The reason why we are asking, we are looking at the economic history of the person, because sometimes some of the gluten-free foods are expensive with our region that we eat a lot of grains and cereals. If the person is going to limit some of the foods, we eat a lot of bread and all that contains gluten. So if the person is going to buy the gluten-free type, can the person purchase it? Or if the person cannot purchase it, what can we replace it with the person? So that's why we are asking all these questions. When it comes to anthropometry, you want to know whether there's any weight change, because some of them come with weight change. When they have issues like this with GI issues, most of them will not eat well. So at the end of the day, they may have some weight changes that we also have to work on it. You have to know whether the person have any lab, whether the person is showing any indication of anemia, because most of them are at risk of anemia too because of malabsorptive issues that they have at the end of the day. And any confirmed ones, anything that the person know that I am allergic, and the person can actually know. Okay, and as I said, whether the person has any other condition like type 1 diabetes, because it's also an immune related disease. So then we come to nutrition focused physical finding. You assess for fat loss, muscle loss, the stool, whether it's loose stool, the person is having bloating and all that, you assess for it. So remember, when we're doing the nutrition assessment, we said that your ability to determine particular tools to use for that particular disease is very, very important. So you see that it is not all the physical findings that we are looking at. We are looking at particularly with somebody who has celiac disease, which is a GI condition. And we ask about GI signs and all that, so that it will not waste much of your time. Okay. So then when we look at the nutrition diagnosis, because it is an initial diagnosis, most people with initial diagnosis always look out for the behavioral domain of the diagnosis. When you are writing diagnosis, the behavioral or environmental domain, because most of them depending, because you remember we asked knowledge question in the nutrition assessment, whether the person have knowledge, whether the person have seen a nutritionist before or a dietitian before. So then we always tackle that one first, knowledge. Okay, so then this is a newly diagnosed patient. He has no idea about gluten-free or what to eat, or even why gluten is causing whatever disease the doctor is saying that he's having. So then the nutrition problem becomes food and nutrition related knowledge deficit. I said the last time that because we use terminologies, we don't use our own words. We don't use our own words to write the PES statement. So I think I sent a document to Adrian to share with the group. Okay, so then because I know it is some form of knowledge deficit, I go into that document. There's a main heading with food and nutrition related knowledge deficits. Okay, it gives you some symptoms that it gives you some etiology or causes that are under that subdomain, okay, or subclass. So for this one, this lady is new to this disease. So it means that he lacked prior exposure to information about that particular disease. So that is why the cause I chose lack of prior exposure to information as newly diagnosed celiac disease. Okay, so food and nutrition related knowledge deficit, which is a nutrition problem label related to lack of prior exposure to the information. The person do not have any information about that condition. And what is my evidence? My evidence, I always said evidence should be measurable. It should be the signs and symptoms that you can measure. Okay, so remember we asked a 3-day food record or 24-hour record. So then in my 3-day food record, it showed me consumption of food containing gluten. Okay, so I have the label, the nutrition problem label. The root cause is the fact that the person lacks prior information about the disease that he or she has been diagnosed with. And then my evidence is that the diet history I took, okay, there was a 3-day, like the 3-day record of foods. The foods that the person mentioned were foods that contain gluten. You can also add additional signs and symptoms. Since we did a physical examination, it can be that the person is complaining of the bloating, the diarrhea, which are all signs and symptoms of celiac disease, which are also measurable because when you put in the intervention of putting in gluten-free kind of foods, that symptom of diarrhea, bloating will stop. So it is measurable. The outcome is measurable. The outcome is that by the time you come back, I expect that the bloating, the pain, the diarrhea would have stopped. So then this is the PES statement that I chose because it fits the nutrition problem that the patient is presenting or the client is presenting, the root cause of it, and the measurable evidence. That's when the person comes for monitoring and evaluation, I can easily measure to see whether the person is having improvement or not. So you see how the intervention was written. It was written under the subclasses. Okay, when you go to the delivery domain, I've planned everything. I've spoken to the person about the fact that the person should eat a gluten-free food. If the person cannot afford, what are the cheapest kind of other substitutes that the person can use? We have spoken about it and everything. And then my food and nutrition delivery, I'm saying the person can take 3 main meals with a snack. Okay, the person is young enough. There was no adequate weight change or significant weight change. So 3 main meals with a snack. Educated. You see, because it's a knowledge deficit, I didn't write counseling. I rewrote education because it's knowledge deficit. You are going to do education, how the person can identify gluten containing food, how the person can read food labels, because there are some foods or the foods that are in sachets. The food itself may not contain gluten, but then the production line has a food that contains gluten. And when they eat that food, they will have a flare up. So I'm teaching the patient how to read food labels to be able to identify the ones that have gluten or traces of gluten to it, the one that have cross-contamination of gluten to it. And then also talking about the one that are gluten-free that the person can take. So I always advise nutritionists, clinical nutritionists, dietitians that always do a food resource by yourself. Move through town, move through the shops that are around, what foods are there, so that when you are dealing with patients, you always know what to write and what is in the local market that best fits your patient. Of care with the medical team and a family member. The medical team, because you want the medical team to know what you have done for the patient, so that when they come back to see even the referring physician, sometimes they also follow up with questions to see if the patient understands what you said. And I said, don't forget the nutrition prescription. I didn't want to crowd the the slide. So don't forget about your nutrition prescription, which could be that from your assessment, the person needs 1,200 calorie diet or a 2,000 calorie diet in a day with this specific amount of protein. You say that you educate on gluten free and gluten containing foods and how to avoid them. Okay. And that will be all for the prescription. All right. I didn't want to crowd the slide and also work within time. So you see the monitoring and evaluation that was put down. So this monitoring and evaluation was put down so that when the person comes, what are the outcomes that we are looking out for? Okay. We are want to assess the compliance to gluten-free diet. Was the person able to comply to it? The nutrition adequacy and diet quality. So after I've taken a 3-day food record again, will I see the quality? Will I see that the person has removed gluten containing foods or the person still have some in it? Would there be any changes in the digestive symptoms the person spoke about? Or if there are labs, is there any change in the labs and nutritional deficiencies the person was having because of the condition? As I said, some people with celiac disease will come with either iron deficiency, folate deficiency, or B12 deficiency anemia. Okay, and then changes in personal motivation levels and factors that may impact the diet compliance. Those are the things I'm expecting that the person will be doing well. So when the person come back for review, that is what I am expecting to ask. But anyway, you have to put it in the intervention, the number of times the patient is supposed to see you and when is the next review time. We have to put it in it without forgetting. So this case study number 2, I hope the case study number 1 was understandable. Study number 2 is for us. If anybody can help us, even we don't have much time, so we can't go through it, just selecting assessments, food and nutrition delivery and all that. But then looking at the case study, what PES statement will you write or what diagnosis statement? At least we can do that one. And then when we go home, we can go over it and see how we put the interventions and everything. So the case study 2 is for us. This is a case of a 28-year-old lady who is referred because he's obese with BMI of 35. So if somebody can help us, okay, if somebody can help us reading it, if any idea of the nutrition problem, the root cause of it, and then quickly then so that at least by in 10-15 minutes we can be done. So who is willing to help us? Who is willing to help us? Okay, Edith's hands is up. You can unmute and then.
I can see that this person is having junk foods, like soft drinks, and she has a sedentary lifestyle. She's not moving a lot, and she doesn't eat at home prepared meals. She eats outside, home, fast foods, and at the restaurant. And she's drastically increased her weight to 20 kilograms in only 2 months. Became obese. So this person is having obesity and have binge eating. That's what I think.
Okay. So then you are saying that the nutrition problem is obesity
Yes.
and the root causes or the etiology.
Mm. I think it's binge eating.
Binge eating.
Yeah.
Okay. Any other person with any idea to at least if we have to, then we can compare.
Like eating junk foods in large quantities, which is evidenced by the increased anthropometric data, visceral fats, which is high, and fat mass, which is high. That is what I'm thinking.
Okay. All right. So then the two submissions are very right, but in order to write it with standard terms, yes, it's obesity, okay? Related to, we have, from the two submission, we all know that the person is eating a lot of energy-giving foods, excessive energy-giving foods. The person is sedentary, okay? So then, in order to be specific, you can choose one, all right? We can't use binge eating because then it puts the person on a disorder kind of range. We want to be specific to actually, so that when our colleague sees it, he sees actually why we are saying that he has obesity. Okay, so then in order to be specific from the assessments we did, we can write then excessive. If you look at the document, they will give you some root causes or etiology. That is all around what our two colleagues has given us. But in order for us to use the standard terminologies, okay, we can say that obesity related to excessive energy intake, okay, related to excessive energy intake, which makes it very clear to everybody, and it's a standard language. If we are picking data on people who were having excessive energy intake, it is very, very clear. We don't want to speak different language. You see, our colleagues all were saying the same thing, but the language they used was two different language. So then that is why we use the nutrition care process, so that we will use a standard language, a language that all of us speak the same way. So when we are starting, it is always advisable to use the document, because already we know how to identify or pull out the nutrition problem label, which is very great. And then we know how to pull out the cause, which we have done beautifully. And then we go into the document and search for it, because in the document you will find obesity as a nutrition problem. And if you look at the causes or the etiology, you will see that there is excessive energy intake. There is other things. There's excessive energy intake. There are other things like disordered eating pattern. There's other things that are not ready for diet or lifestyle change, physical inactivity, increased psychological stress, and all that. So depending on which one your patient is exhibiting, you pick that language, you pick that terminology, so that when we write it, we are all saying the same language, we all say the same things at the same time, okay? So then our PS statement becomes obesity related to excessive energy intake, evidenced by, as our colleague said, we all saw the BMI, which is 35, and then increase adiposity. Our colleague also stated it, that increased adiposity. We can be specific and then write BF, body fat percentage, was 42.9%, which is high for a female of her age, as our colleague indicated. Okay. And then our other colleague indicated that the fact that he eats outside the house most of the time, and then the amount that he's eating is huge. Okay, is huge, large portions. Large portions of food. Sorry. Large portions of food. So then the PS statement becomes, sorry, somebody. Hello, please, I hope you can hear me.
Yes, we are hearing you.
Okay, sure, thank you. So the PS statement becomes obesity related to excessive energy intake, evidenced by BMI of 35, increased adiposity of body fat percentage of 42 points, I think it was 7, and then large intake of large portions of food. Very simple, very realistic, and something that we can develop an intervention for. Our intervention will be looking at the root cause, which is excessive energy intake, and then our monitoring and evaluation will be looking for how to reduce the BMI and the adiposity, which is measurable. If it's going down, we can measure to find out that it's going down. If we want to look at the intake of food, we can still take a food record or 24-hour record to find out whether she's eating those large portions again or not. Please, you get me?
Yes. For me, I got you.
Yes, please.
Gotcha.
So very simple. It is easier if you are using, it is easier if you use the document from the beginning. When you are writing it with time, you get familiar with the terms. And I think Joseph's hands is up.
Yes, we can hear from Joseph.
I was also going to state another second nutrition diagnosis, looking on the case study.
Okay.
I was going to say like inappropriate carbohydrate intake, because in the case shows that the patients have been taking soft drinks and etc. So I would say inappropriate carbohydrate intake related to nutritional knowledge deficit, that evidenced by increase of obesity or weight increase. Yeah, as showing that in the case study.
Okay, excessive carbohydrate intake, because it has shown, and then evidenced by BMI again, right?
Yeah, sure, yeah.
Okay.
Or weight increasing.
Or the weight increase. Yes. Good. So it looks like we are all merging at the same place. So that is very, very good. That is very, very good. Sorry, I think I put it under assessment. So we can all, maybe we try our hands on it individually at home. We can discuss among ourselves, okay, how best we can do it. Unless anybody have a question, or we move to the intervention. If somebody can help us with the intervention, what you believe we can plan for this patient, we can plan for this very quickly so that we'll be able to end it. Intervention. planning the intervention. Please, can somebody help us with that one too? Planning the intervention. Oh, my people, it's like everybody is quiet on me now. Okay, Edith wants to help again. Edith, please, can you unmute?
Yes, the intervention would be reducing excess intake of carbohydrates or energy intakes and replacing them with mostly vegetables and fruits or foods rich in fibers, and again reducing fatty food and eating prepared meals, not junk foods, drinking appropriate amount of water. I think that's what I've got. Let's other people help. Thank you.
Okay. So thank you very much, Edith. So how are we going to, I want us to go over this one a little bit. So how are we going to specifically reduce or replace reducing the energy intake? How are we going to specifically do that? And if we need to replace, what are we replacing with specifically? So Joseph, if you want to help us with that, I think I've seen your hands raised.
Okay, for me, I would propose portion size control since the patient is taking to large portion size. So be first of all portion size control, and second increase of fibers intake, which we in his diet, that will contribute to increase of fullness, and instead of taking too much carbohydrates and other nutrients food. So I would increase fibers intake, where I will be including fruits and vegetables. And the third intervention, I would include also physical activity three times a week, with starting from 15 to 20 minutes top, and also be increasing gradually. So that's my three intervention that I can start. Yeah, thank you.
Okay. So then, when we from what I get, first of all, we do portion control. So then if we are going to go according to the domains that was given us, so food delivery, we want to do portion control. As our colleague and Joseph is saying. So it means for her, asking her to take three main meals. Maybe we are doing 1,000 calorie a day, and then we are portioning it into three main meals. And I believe that from what this was saying, it means that we are going to who has raised their hands? Esther, please, you can go ahead.
I'm sorry to take you back a bit. I was taking a phone from work here. So, but I didn't see if you calculated the requirements of the patient before starting to mention the interventions. Did you? Where did you get this 1, 2?
1,002. So we didn't calculate.
So why
calculation. I said, do you want us to calculate? We can calculate. There are so many methods to calculate, but if we are using, did the question give us the actual weight? Yes, it gave us the actual weight. So
yes,
if we
are 74.6.
Yes, so then we can use the quick method. The quick method is uses between 20 to 25 kilocalorie per day. If the person is obese and sedentary, I think so. There's the Harry-Benedict equation. There's the Mifflin equation. Any of them that you want to use, but then I always advise that we use the quick formula because in clinic we don't really have time. We don't really have time.
Excuse me a bit.
Mm-hmm.
Do we calculate depending on the actual body weight if the person is obese, or we just calculate the ideal body weight and calculate depending on that?
You can even use the weight that you measured when the person came. When you are using the quick method. When you are using the quick method, because the quick method has considered all that, okay? The quick method has considered all that. You can actually calculate. I'm trying to see if I can project the quick method for us to see quickly so that it gives everybody an idea what you are trying to talk about. All right, so the quick method is done in such a way that it has been divided into sedentary, I felt I had a very quick one somewhere that we can use. Just 1 minute, I'll quickly project it. Okay, let me end the sharing of this one quickly. Okay, so this is just a quick one for everybody to understand the question that Esther asked. So then there are so many ways to determine the energy needs of a patient. The golden standard is the indirect calorimetry. That is the gold standard that we use as a professionals, but the indirect calorimetry needs instrumentation and other things. So most of the time it is very unrealistic in our setting to do that. So then we can use the quick method. Okay, the quick method considers whether the person is overweight or whether you want to do weight reduction, and it also considers the activity level of the person. So there is no need for you to calculate the ideal body weight, okay? Or you can straight away use the weight that you calculated or the weight that you measured, when the person came. That is fine. It has sections for normal people, normal sedentary, normal moderate activity, normal heavy and strenuous activity. That's why it's a quick method. It is something that you can quickly do in clinic so that you don't waste much time. But then if you want to use other formulas like the Harry Benedict formula, you can do it. There's a formula you can input some indicators and you can also measure. There's a Mifflin method that can be used. There are other newer methods. Recently, I saw a paper that actually even brought an equation for older people more than 65 years. I will share that article. So then there are so many ways you can do look at calculate. Even the Schofield method is, or the tables for Schofield is used for children mainly. You can use it to determine the basal metabolic rate and then multiplied by the activity factor. So there are so many ways you can do that, okay, depending on what actually you want to see. And what you are calculating for. Joseph, do you want to add something?
Yeah, sure. I want to ask something like, as you're mentioning that there's those formula to calculate the energy requirement for the patient.
Mm-hmm.
But I also want to ask, like when you are in weight management, there is a way you create a caloric deficit of 500 per day, which is overall per week is 3,500 calories per week. So if after calculating the daily energy requirement of the patient, do you have to subtract that too? Or like you just have to go with what you have already found through the calculations? Thank you.
Okay, so then you subtract. You see, the calculation that you are doing is to estimate the energy requirements of the person.
Sure.
So if you want to do create a deficit, you can subtract between 500 and 800 calories depending.
Okay.
But we all depending on like the plan and the outcome you have for the person.
Okay.
We always say that don't do any meal plan which is below 1,000 calories for a person.
All
The
right.
reason being that the person will have micronutrient deficiency. Okay,
Sure.
so then we always stick to the 500, and sometimes we start from 300, depending on how best. You see, we are doing patient-centered care, looking at how much the person is eating. If your deficit is 500, it makes the food so small, it's difficult for the person to comply. So then you can start with 300. If the person is doing well, then you create a deficit of 400. If the person is doing well, you create a deficit of 500. You see, so depending on your patient, every patient is different. But then when you are doing weight reducing, you always have to create that deficit. It's very important so that the person can use some of the stored fat as energy and then can help the person to reduce the weight. Okay, so for the benefit of the question that Esther was asking, you can use this calculation to calculate the estimated energy requirements for the individual. We are saying estimated, okay? It is only when you are using the indirect calorimetry to calculate, that is when you actually get the actual energy requirement. But then every other method, whether it is Harry Benedict or Mifflin or Schofield, or the FAO tables, they are all estimated, okay? They are all estimated because precision is not 100% when it comes to that. So then that's how we get the energy requirement. Then you put the energy requirement into the foods that you want to control the portion size. And as Joseph said, you can create a deficit. But please do not create a deficit below 1,000 calories. It's difficult for the patient to achieve that. The patient can have micronutrient deficiencies that you don't want. You don't want to create a problem while solving another one. and then you input your high fiber. That's when you input your high fiber. But please, because you have to be specific in the intervention, how much of fiber. So in the prescription, you have to tell us whether it's 25 grams of fiber a day in the plan that you are doing. Okay, that how much of fat, because it's a weight reducing something, how much of fat, how much of grams of carbohydrate is coming or contributing to the total energy of for the day, how much of fat, how much of protein, and in that in the fat, how much of saturated fat actually. Because when it comes to obesity, we want to be very specific because obesity is a risk factor for a lot of non-communicable disease. The question said he doesn't have any family history of that. That is good. But we are also doing preventive whilst we are managing the obesity. So then we have to be specific in all this. And then we write the prescription, then come down to write. That's why I said that, yes, we are reducing carbohydrate, we are reducing energy, but we have to be specific with values, okay? How much we are reducing this, what we are giving in terms of this, the exercises. I think Joseph said 3 times a week, 15 to 25 minutes a day. Okay, what can the person do? Can the person do swimming, walking? You talk to the person about it. I can do walking, okay, I can do dancing, I can do gym. Then you specifically put it there that the person says he will do the exercise, he will do walking, he will do gardening, he will do a mixture of exercises. How you discuss it with the patient, but because it's a planning and you are going to implement, it has to be specific, okay? So that when the person come and you are putting down the outcomes, you are also specific with the outcomes. When you go to the next, like the monitoring and evaluation, and you are putting it down, you are also specific about it, that this is the outcome we expect. The person, it is recommended that at least the person should lose 0.5 kg in a week. So then we are aiming that we are going to lose that. But if the person do not lose up to what you give, it is good. What we don't want is an increase. As long as there's no increase, that is fine. When the person comes back, it is when there's an increase, that's when you realize that the person did not do anything that you asked the person to do. So then if you are not specific with your intervention, it makes it difficult when the person come back and you are actually comparing what was said, what was there, and what has been done. But if you are specific, the person comes back, you take the history again, you can see that, okay, this person is going according to the calorie estimation that we did, the amount of fiber, because we all agree from Edith and Joseph's submission, there should be high intake of fiber through vegetables and fruit, and then there should be exercise. And then it is talk about replacing the juices. Okay, replace the juices, not really with fruit juices, but actual fruit, because now if we are giving about 25 grams of fiber in a day, we want the person to, as much as possible, eat the actual fruit that the person will get the fiber from it. He can make a smoothie with the fruit, but we know that you reduce the efficacy of fiber when you keep on blending. So most of the time, there are patients that we encourage that, can you eat the orange like that, so that you'll be able to eat the inner portions with the insoluble fiber that is in it. It is good to consider soluble fibers too, which is also good, okay? So I think that we all have an idea what to do. What we have to remember is that we are being very specific, okay? Joseph?
Yeah, I'm sorry, like I've been asking a lot of questions.
Oh, that's okay. We are discussing.
Okay, sorry. So I'm glad that you brought this thing of how much weight to lose per day or per month. So because we have been having some of our colleagues just like patients want really rapid outcome from their weight, and maybe sometimes that's why some of us are pushed by the desire of a client, but which is beyond the recommended evidence-based recommendations. So, like we focused more on nutrition intervention and etc. I don't know if I rushed, but I also would like you to even to talk about some of lab work that we can also request for the patients, and how is it going to help us in our management of this kind of patients, and also which ones to focus on during the follow-ups, and also to capture that because we have this habit of not also asking labs work for our patients to manage that. So our patients outcome. So I also want you to reflect on that, so because it's going to help us to work on also on that. Thank you.
Okay. So then, depending on the condition, okay, let me tackle the weight target first. It is always to work with a weight target. We are doing patient-centered care. We are looking at preference for patients, but then we are also there as clinicians to also advise the patient which one is a healthy way of reducing weight. So weight reduction is a lifestyle change, a behavioral change, and then behavioral change takes time to be able to be effected. I can help you to lose 10 kg in a month, but is it healthy? No. Your heart knows. I always use this analogy that, let's say I have a V8 4x4 Toyota, okay, and I pick the engine of a Toyota Viz, and then all of a sudden I put it in the 4x4, it will never work. So it's the same with our body and our body organs. If I want you to have a very healthy way of reducing weight, we have to do it gradually for your heart to accept what is going on. And it's because you have done it gradually, it becomes a way of life, it becomes a lifestyle, it is sustainable. We want to do something that is sustainable for our patient. Not if the patient don't learn how to eat that estimated calorie gradually. The patient can do that in 2 months. We really restrict, lose the weight, but gain a double of it in 3 months' time, because the patient has not learned, has not gone through that behavioral change to actually effect the change. So that is why for us, we want to go the gradual way, give set targets, then we meet the target, then you move on. By the time in 6 months' time, when the person has actually achieved that 10 kg weight loss or 15 kg weight loss, because he has done it in a very long period of time, 6 months to 1 year, it is easier for the person to maintain that way of life, that lifestyle, so that the person will not gain it back. Most of the time, you put your body in a deficit when you are so quick in caloric restriction. Your body, your basal metabolic rate just drop, okay, because you are losing the weight, or you are starving yourself in terms to lose your weight, the weight. Your basal metabolic rate that goes down, you lose the weight. When you start eating like regularly again, your body tends to store more fat for you, because then you are telling the body that probably you will starve yourself again. So that's why we don't want the drastic one. We want the gradual one to teach our body that this is how we are going to eat. Don't store fat for us. We want to use the energy we are eating. We want to use it, and we don't want anything stored. Okay, so that's what I can say about that. When it comes to labs is related to the conditions that you are saying. Depending on the condition, you can ask for labs. There are some health facilities that do not put in the scope of work for a clinical nutrition to write lab. There are some that also put it in the scope of work. There are some too that the organization, we can speak to it, that we know and we understand the labs. So give us opportunity to write nutrition related labs. Okay. Some hospitals will allow. So depending on the condition you have, if it's diabetes, you know that when the patient comes, you want to see glycated hemoglobin, you want to see fasting blood sugar, random blood sugar, lipid profile, you want to see renal function test, liver function test, all those ones you can write. So depending on the condition, if it's obesity, I want to see lipid profile, I want to see fasting blood glucose, if the person can afford, I want to even see glycated hemoglobin, so that I will know, because as I said, obesity is a risk factor for all. And some of these conditions will not be written on the person's face. So when you ask for the lab, because the person may work in your office, come with obesity, but by the time you ask for the labs, the sugars are everywhere. Okay, so then depending on the condition that you are seeing, you can ask for appropriate labs for you to help the person do a better management, or even do a preventive management, if I should say, because you are managing one and then you are preventing the other one from coming. So for me, we should know one thing, that we have to know the kind of condition and the kind of labs, because if we don't know, then we write the lab admits and then we call financial loss to people, which is also not very ethical. Okay, so that's how I'll answer that one. Yeah, thank you. Esther?
Yes.
Yeah.
So, are we all satisfied with what Harriet answered to our questions? Or if anyone with another question, he or she may raise a hand. And oh, Joseph, you have a lot of questions, my dear.
My last question. Sorry. So once you have opportunity to ask, you should ask at least. You ask yourself and you ask for others. So
yeah, I know.
I want to ask Harriet as a dietitian. How about is there like evidence based regarding the use of blood groups to manage of different health conditions? So because we have been seeing some of our colleagues and hearing that theory, but I want to also to reflect on that. What do you think as a clinician? Is it something is evidence based we can use so that we can also help our loved ones and clients? Thank you.
All right, thank you so much. Thank you so much. This question has been thrown over and over again, and I'm going to answer it as a clinician, okay, and also as a researcher. When we talk about evidence-based, it means that a work that has been done in a large group of population in different geographical areas, and then we have come out with evidence that, okay, this is what is happening. It is a cohort study. We have followed people for so many years, and this is what is happening. One disadvantage of blood group dieting is that there is no major research showing the work that was done in different categories of people. There is, as at now, I can say that I've not seen research in different category of people, Black, Hispanic, Caucasian, showing the effectiveness of blood group diet. So then we don't put it as an evidence-based guideline. When we are talking about evidence-based guideline, we don't put blood group dieting and the evidence-based guidelines. So then in our work as a professionals, we don't really consider blood group dieting as such, because if you look at different geographical areas, there are different blood groups. When you come to Africa, most of us are having the blood genotype O. Caucasians have different, and Hispanics have different. And when you look at the blood group that the person followed up mostly with Caucasians, okay? So you see that the food that are being recommended are mostly food that are familiar with a Caucasian related ancestry. So then it is difficult to really conclude that the same thing will work in an African ancestry kind of population. So that would be my answer, my professional answer to that question. So let's be careful how we use it. Yeah.
Thank you, Harriet. Any other question? Okay, so we are all done and answered. Okay, before I like conclude, I want most of you to show us your faces and we say hi before saying goodbye. I can see Lauben, Colombe, that is Joseph Karemera. Hi, Joseph. Hi, Sylvie. Chiri.
Hi.
Edith.
Hi.
No any other person online?
Rwanda Nutrition Society is showing their video.
Rwanda Nutrition Society is Adrian. Okay. So guys, I'm really happy for you to follow this training. It's really important to understand the whole nutrition care process in what we do to our patients in daily lives. So in any institution you are working from, always remember that Harriet have talked about this, and we have to consider that it's really important to follow the process correctly and help our patients appropriately. So if there is any other question, and maybe Harriet doesn't any other thing to add before we conclude. Harriet, do you have any other?
Okay, I really don't have anything. I just want to say murakoze chana to everybody.
Okay, murakoze chana. How do you say that in your language?
Medamasi bebre.
Huh?
Medamasi bebre.
My dear, I can't this time your language is becoming complicated compared to your language. Okay, so thank you very much, Harriet, and thank you everyone for attending. Before we conclude, I want to welcome Adrian as a person who is from Committee of Awareness. I didn't see Kamanzi Private either and other people from committee. I don't know what happened to them. They didn't follow the training, but maybe Adrian can come and say something before we conclude.
Okay, thank you so much for this time. On behalf of the President of Rwanda Nutrition Society and the whole committee, I would like to thank everyone who is attending this session, and also thank our presenter, Harriet. Thank you for your time, thank you for your kind care for all nutritionists in Rwanda. May God bless you. There is one question from Claudette. It's not a question, it's a suggestion to consider the to send this presentation, and I know Harriet will share the presentation to us and we will share to everyone. I think there's no problem. So for the next plan, we will share other plans, and you know that we have a lot of to run. And Harriet is here with others who have main knowledge to share with us. So I want to stay with this platform. So, and I'm sure that we will learn too many things because we are in the world where everything is being updated every time. So, and even us, we have to learn everything and to stay updated every time. Thank you so much. And also thank you so much to our moderator, Esther. Thank you for your time. I think your baby is calling you, but you have a patient and you stayed with us. So thank you so much. And you also, God bless you. Thank you.
Thank you too. So before you close, I want Harriet. Harriet, are you still there?
Yes, I'm here.
Okay. Like after completing this, I know there is someone who asked about how to okay, calculations. We have seen how to do energy estimation, but after this, I can propose for you to teach us how to do meal planning and menu distribution, and then nutritive value calculations depending on the the local food we have, using the Tanzanian food composition table. Next time, maybe you can choose a case maybe from Sashika, from any institution, and then someone can present it and you help us to learn from that case by doing menu planning and the other things that regarding intervention. Thank you.
Yeah, sure.
Okay, so thank you. You're free to go. Bye-bye.
Bye.
Yes, bye.
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 There are some people who are raising hands. If they know if they want to say something. While we have been closing. I don't know if they have questions, but we are at the end of the presentation. Maybe they will ask for next time.